Hello, my name is Brenda Hervieu. I am a PhD student in Optimal Protection Society. This presentation is about the effect of an inhalation chamber without inspiratory valve and face mask for neonate use on drug delivery. As we know, aerosol therapy for infants seems to be difficult and inefficient. Indeed, less than 2% of drugs are inhaled when using a PMDI with a VHE. This can be due to the very low tidal volumes, which is approximately 25 milliliters compared to the dead space volumes of commercialized VHE with face mask, which are between 43 and 150 milliliters. This difference caused some difficulty to open the inspiratory valve of this chamber. A previous clinical study suggests that using a spacer without inspiratory valve was more efficient to treat infants. Another factor that could affect drug delivery when using PMDI with inhalation chamber for neonates is the cooperation of patients. In fact, a decrease of drug delivery to the lung was reported in crying children compared to the quiet children. And applying a mask on a baby's face during few seconds could result in the baby's stress and crying and reduce drug deposition to the lungs. So, the aim of this in vitro study was to, in the first part, evaluate the in vitro performance of an inhalation chamber without inspiratory valve to be used with neonatal model and compare to the in vitro performance of a classic VHE with different drug used to treat neonates. In the second part, the aim was to understand the effect of the number of breathing cycles after each PMDI dose to determine how long it might be necessary to apply the inhalation mask on the baby's face after drug administration. To assess the performance of an inhalation chamber without inspiratory valve, two different studies have been carried out. The first was performed with salbutamol, which was actuating during the inspiratory phase or during the expiratory phase to reflect coordinated and uncoordinated use, respectively, in separated tests. This measuring bench was composed of a breathing simulator from Copley Scientific to create the breathing pattern of neonate. An hydrophobic filter was placed between an infant face model and the breathing simulator to collect the drug. The face mask was applied to the face model with a force of 0.8 kilograms. The breathing simulator operates continuously between the actuation of the PMDI. In total, 5 salbutamol doses were actuated into the chamber with 1 minute interval between individual actuation in order to have a sufficient amount of medication on the filter to allow a UV quantification. The second bench was performed with fluticasone propionate, which was actuating during the expiratory phase to reflect uncoordinated use. This measuring bench was an in vitro in vivo correlation. It was composed of a breathing simulator, an USB induction port, a next-generation impactor called InGI, allowing to sample the emitted aerosol by means of TPs called mixing inlet. A constant flow rate of 15 liters per minute across the InGI cascade impactor was balanced by a pressurized dry air source, resulting in simulated tidal breathing via the VHE and constant airflow in the InGI. The inhalation chamber with face mask was again applied to an infant face model with a 0.8 kg force. Measurements were performed with a breathing simulator running continuously between the actuation of the PMDI. In total, 10 actuations of fluticasone were done during the expiratory phase with 1 minute interval between individual actuation. The distribution of fluticasone at the different stages of the InGI was used to determine the APSD, the total mass of fluticasone recovered within the impactor, the fine particle dose, and the particle mass median aerodynamic diameter. The last bench allowed to evaluate the effect of the number of breathing cycles to know how long it might be necessary to apply the inhalation mask. During this study, beclomethasone propionate was actuated during the expiratory phase to reflect uncoordinated use. This measuring bench was composed like the first bench. The breathing simulator operates with different number of breathing cycles between the actuation of the PMDI. The number of breathing cycles was from 2 to 40, which represents holding from 2.6 seconds to 51.2 seconds. In total, 5 beclomethasone dipropionate doses were actuated into the chamber with 1 minute interval between individual actuation. Results for the performance of an inhalation chamber without inspiratory valve were expressed in percentage of the total mass of salbutamol. Green histogram represents the result for the use of an inhalation chamber without inspiratory valve, and the blue histogram presents a classic VHE. The left of the plot represents results for synchronized actuation, and the right of the plot where the actuation was uncoordinated with the inspiratory phase. The low value of drug deposit on the filter with VHE, so 3 or 4% of the nominal dose, are consistent with drug deposition reported in previous study to treat neonatal and infant patients. The deposit drug mass when using Tipsaler without inspiratory valve were significantly higher than when using the Tipsaler classical version. These results were significant independently of the synchronization of the actuation with the inspiratory phase. Results for another study to show performance of inhalation chamber without inspiratory valve on the in vitro in vivo correlation bench. This figure shows the value of impactor total mass and fine particle total mass of fluticasone propionate obtained with the APHD measurement when using Tipsaler without inspiratory valve, green histogram, and when using the classic version of the VHE, blue histogram. The total mass of fluticasone collected in the NGI with the valve holding chamber is very low. This may be due to the dead volume, which includes the volume of the VHE, of the mask, and inspiratory. This dead volume is larger than the tidal volume, which would prevent drug from depositing in the impactor. It is supposed that the drug could deposit in the NGI due to the breathing pattern and the number of the breathing cycle. Indeed, the inhalation profile has a higher amplitude than the exhalation profile, which could allow some drug particles to not be expelled and to enter the impactor during the next inhalation phase. Both impactor mass and fine particle mass were significantly higher when using Tipsaler without inspiratory valve in comparison with the classic version of Tipsaler. This table shows the MMAD obtained with the two inhalation chambers. MMADs were not statistically different when using Tipsaler with or without the inspiratory valve. This figure presents the delivery of beclomethasone dipropionate obtained as a function of the number of breathing cycles after each PMDI dose release with the inhalation chamber without inspiratory valve. The delivery mass of beclomethasone dipropionate increased with the number of breathing cycles up to 14 cycles corresponding to 16.2 seconds holding duration. However, the mass deposited after 2 breathing cycles was higher than 50% of the maximum dose deposit. These in vitro results were obtained in ideal conditions. In the clinical situations, it could be interesting to consider the benefit of using a protocol involving administration of 2 drug doses instead of 1, and applying the mask for only 2.6 seconds twice instead of once for 16.2 seconds holding duration to avoid and reduce stress and crying of the baby. These in vitro data offer new perspective on how to treat neonates. The results obtained show that the drug deposition for neonates seems to be negatively affected by the dead volume caused by the inspiratory valve. Indeed, the inhalation chamber without inspiratory valve was associated with more drug mass per actuation deposit together with a higher fine particle mass. To treat neonates, an inhalation chamber without inspiratory valve seems to be better compared to the use of a classic VHE. The effect of the holding time of the face mask on the face model after an inhaler actuation on the in vitro drug delivery was evaluated with a VHE but not plotted here, and with a device without inspiratory valve. This finding obtained rather question. What is more beneficial for clinician and patient? Using 2 pmDI doses and holding the mask for 2.6 seconds twice, or using 1 pmDI dose and holding the mask on the baby's face for a longer time, with the risk of reducing the drug dose deposited because of the baby's crying. Thank you for your attention. If you have any question, you can write on this email.